Welcome to my YouTube channel. Thanks very much for subscription. For those who subscribe, those who have not yet subscribed, please do one thing: subscribe and put on a notification. Today we are going to look at renal pharmacology, basically looking at the drugs which have their effect on the renal system. These are diuretic drugs. So in order to understand this context, we are going to first have a brief review of the kidney and basically the nephron. The nephron has the glomerulus, the proximal convoluted tubule, the loop of Henry, and distal convoluted tubule leading to the collecting duct. So at the proximal convoluted tubule, we have reabsorption of sugars, amino acids, and sodium. And here we have two classes of drugs that act at this point, that is the carbonic anhydrase inhibitors and osmotic diuretics. At the loop of Henry, on the thick ascending limb, we have sodium, chloride, potassium, magnesium, and calcium reabsorption. And here we have the loop diuretics acting at this point. Going to the distal convoluted tubule, we have the point where we have the macula densa cells. These produce renin. We have sodium chloride reabsorption and calcium reabsorption. And the drugs which act at this point are the thiazides. Then when we continue to the collecting duct, that's where we have loss of potassium and hydrogen ions, then reabsorption of sodium and water. At this point, we have a diuretic hormone acting on the collecting duct. Then the drugs which basically act at this point are the potassium sparing diuretics. Going to look at these drugs, we are going to have them being categorized into their uses and side effects. Starting with the loop diuretics, they are also referred to as the high ceiling. Examples, you have furosemide, bumetanide, tosemide, and ethacrynic acid. Their mechanism of action is blockade of the luminal sodium potassium chloride transporter in the thick ascending limb of loop of Henry. It does selectively inhibit sodium chloride reabsorption in this thick ascending limb. Due to the large sodium chloride absorption capacity of the thick ascending limb, loop diuretics are among the most efficacious diuretic agents available. What are the interactions of these drugs? When they interact with drugs like NSAID, those are non-steroidal anti-inflammatory drugs, or probenecid, they are going to have a decrease in the effect of this diuretic drug by the competition of weak acid secretion in the proximal convoluted tubule. When they interact with aminoglycosides and cisplatin, we have a synergistic effect in causing ototoxicity. When they interact with potassium sparing diuretics, there is reduction in the hypokalemia caused by loop diuretics. What are the side effects? The side effects, we have hyperuricemia, ototoxicity, hypomagnesemia, hypocalcemia, hypokalemia and alkalosis, then sulfonamide hypersensitivity. The indications of these drugs are hypertherapia, hypercalcemia, then refractory edemas, acute renal failure, acute pulmonary edema, hypertension, and anion overdose. The second category of drugs is the thiazides. And the thiazides, examples we have here, we have hydrochlorothiazide, benzithiazide, cyclothiazide, benzoflurazide, and metolazone, and all contain a sulfonamide moiety. And the mechanism of action of these drugs, basically their site of action is the distal convoluted tubule. Thus, they mainly reach this proximal tubule. They reach by proximal tubular secretion, as they are highly protein bound and less filtered. Then the action is blockade of sodium chloride exchanger in the distal convoluted tubule. In contrast to the situation in the thick ascending limb, where loop diuretics inhibit calcium reabsorption, thiazides actually enhance calcium reabsorption. And what we have to note here is that at higher doses, administration of some of the thiazides results in some degree of carbonic anhydrase inhibition. However, at usual doses, only chlorothiazide shows any appreciable carbonic anhydrase inhibitory activity. What are the drug interactions of the thiazide drugs? When they interact with cardiac glycosides, for example, digoxin, they precipitate cardiac arrhythmias. So when they interact with oral hypoglycemics, for example, sulfonylureas, there is hyperglycemia due to thiazide-reduced insulin secretion. Then lithium, increased lithium plasma levels due to enhanced tubular reabsorption. When they interact with uricosuric agents, for example, probenecid, there is reduced uricosuric activity due to decreased tubular secretion of the uricosuric agents. What are the indications of these drugs? We have hypertension, congestive heart failure, nephrolithiasis, nephrogenic diabetes insipidus. And the side effects caused sulfonamide, hypersensitivity, hypokalemia and alkalosis, hypercalcemia, hyperuricemia, we have hyperglycemia and hyperlipidemia. Then moving from there, we are going to go to another category of drugs. These are the potassium-sparing diuretics. Examples, we have spironolactone, tramterene, and amiloride. The mechanism of action, they act on the collecting tubule. When you look at amiloride and tramterene, they are organic bases that lack sulfonamide group, directly interfere with sodium entry through the epithelial sodium ion channels in the apical membrane of the collecting tubule. Since potassium secretion is coupled with sodium entry in this segment, these agents are also effective potassium-sparing diuretics. Another drug is spironolactone. It is a synthetic steroid that acts as a competitive antagonist to aldosterone at the aldosterone receptor. The actions of the aldosterone antagonist depend on renal prostaglandin production. So what are the uses? Spironolactone is used in hyperaldosteronic state, and it can be used as an adjunct to potassium-wasting diuretics, can be used in treatment of congestive heart failure. The side effects are hyperkalemia, acidosis, and anti-androgenic effects. Amiloride and tramterene, they are used as adjunct to potassium-wasting diuretics, lithium-induced nephrogenic diabetes insipidus. The side effects are hyperkalemia and acidosis. Moving to another category of drugs, these are the carbonic anhydrase inhibitors. The example we have here is acetazolamide. These acetazolamide and dozalamide, their mechanism of action and the site of action is the proximal converted tubule. They inhibit carbonic anhydrase enzyme, thus decreasing the bicarbonate reabsorption in the proximal converted tubule. This results into increased excretion of bicarbonate, sodium, and water, which we refer to as diuresis. What you have to note here, the diuretic efficacy of acetazolamide decreases significantly with use over several days because reduced bicarbonate in the glomerular filtrate leads to enhanced sodium chloride absorption by the remainder of the nephron. The uses we have, it can be used in the treatment of glaucoma, acute mountain sickness, and metabolic alkalosis. The side effects caused here we have bicarbonaturia and acidosis. We have hypokalemia, we have hyperchloremia, paresthesias, then renal stones, and sulfonamide hypersensitivity. Then another group of the drugs we are going to look at is the osmotic diuretics. Examples are mannitol, which we normally give intravenous. Isosabide, we give orally. These are small, freely filtered, but non-reabsorbable molecules that inhibit passive reabsorption of water. What are the uses? We use them to decrease intraocular pressure in glaucoma. We can use them to decrease intracerebral pressure and in oliguric states. The side effects are acute hypoparathyroidism